Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 93. Diet. I've long thought it interesting how much what we tell people to eat in pregnancy changes over time. We make new discoveries. Foods that were once encouraged in pregnancy, perhaps liver, become frowned upon. This change can be immensely slow, but sometimes when it's a little bit faster, it can be very baffling for women, particularly if they've had a large gap between pregnancies. They've had a pregnancy many years apart and discovered that the advice that they followed in one pregnancy has radically changed to something totally different this time around. One of the important aspects of booking in with the midwife early in pregnancy is to give some of this dietary advice. What to eat, what not to eat. And I've always made the assumption that this advice is beneficial. In the UK, in the NHS, access to a dietitian during pregnancy is rare. There's very limited capacity in the NHS. And it used to be that I could refer to a dietitian solely women that had a very high body mass index, who had severe obesity, or those with diabetes or gestational diabetes. It was always difficult to refer to dietitians or nutritional services, partly because they didn't sit within the hospital, within secondary care. They sat either in primary care or with the local council as part of public health. The increasing numbers of women with diabetes in pregnancy and increasing numbers of women with obesity mean that even these women now have extremely limited access to dietary advice and support. This brings the responsibility back on us, the rest of the maternity service workers. And I'm ashamed to say that as an obstetrician, I don't talk about diet that often. It's something I rely on my midwifery colleagues to do. I will have the occasional conversation, yes, but it's far more incidental. Maybe it's the result of a blood test or a direct question from a woman rather than at my instigation. And perhaps I shouldn't chastise myself quite as much because, let's face it, if I've got 15 or 20 minutes to see a woman, I simply haven't got the time for this sort of nicety. I had been turning this topic over in my mind for some time. It's one of those episodes that's kind of been at the back of my mind, waiting for the right moment. Then up popped an excellent episode of The Midwife's Cauldron. Katie James interviewing Lily Nichols, a dietitian nutritionist from the USA, with an incredible detailed knowledge of nutrition and pregnancy. Listening to that episode, which I highly recommend, revealed to me the depths of my ignorance. Feeling slightly humbled, I thought this was a topic that I really needed to explore, and the time was now. And given my practice is in the UK, I thought I should get back to what we're telling women here in the UK in the NHS. As I started to explore the topic, I realised, rather embarrassingly, it's a very long time since I read anything about pregnancy nutrition. As an obstetrician, I have to do regular, continuing professional development a certain number of hours each year. But I couldn't remember any recent kind of review or update about diet. Let's see what's available. The first thing I found was the RCOG Patient Information Leaflet, written and published in 2014. I suppose that's not too bad, but it is 8 years old. When I looked at the small print, I discovered it's based on information from NHS Choices website and the RCOG Scientific Impact Paper, Nutrition in Pregnancy, dated September 2010. When I clicked the link to try and read this scientific impact paper, it's been archived. It isn't accessible anymore. So in other words, the RCOG information is a bit out of date. Broadly speaking, when I'm thinking about diet as an obstetrician, diet in pregnancy splits into two categories. First, what we would like people to add into their diet. And second, what do we want people to exclude from their diet? In terms of adding into the diet, I would like to think we're better at this, but in actual fact we may not be. The message of the importance of folic acid in reducing neural tube defects such as spina bifida and cleft lip and palate have been around for ages. But do we always remember that some women need a considerably higher dose? The standard dose of folic acid supplementation is 400 micrograms. But some women need 5 milligrams, and this needs to be prescribed by a doctor. If you have celiac disease or diabetes, your body mass index is above 30. You have sickle cell anemia or thalassemia. You've had a previous pregnancy affected by spina bifida. You're taking medication for epilepsy. All these women need a significantly higher dose. And in terms of timing, ideally you should be taking this before you conceive and continue to take it until 13 weeks of pregnancy. By the time I see women as an obstetrician, it may be too late. There's also evidence that a significant number of women require additional vitamin D. This is because it's common to be vitamin D deficient in the UK. And again, there are some women that are particularly likely to have low levels of vitamin D, partly because of what they eat, possibly because of their ethnic background. South Asian, African, Caribbean or Middle Eastern women are likely to have lower levels of vitamin D, as are women again with a body mass index over 30, or those that don't go out and get exposed to sunlight that much. What about iron? That's the commonest thing that people think they need additional supplements of. Don't necessarily need additional iron. Your blood count will drop a little bit, and that's normal because your blood plasma will be increased and therefore there's a slightly dilutional effect. We will routinely check your blood tests at booking and at 28 weeks and start some iron supplements in those women that need it. Historically, women have struggled with iron supplementation because they get bad side effects. It can cause diarrhea or constipation. But for the most part, this is our fault. We used to give iron twice or even 3 times a day in an attempt to improve and treat anemia. However, this high dose isn't well absorbed and is more likely to cause these gastrointestinal side effects. New guidance suggests that iron absorption may be much more effective if iron tablets are given once a day or even alternate days. The most recent advice in the British Journal of Haematology on iron supplementation in pregnancy recommends that iron supplements should be taken on an empty stomach and with vitamin C supplementation to aid absorption. So we should be giving a low dose every other day on an empty stomach with vitamin C. I can't say that I have managed that well during my career, if I'm completely honest. This guidance also clearly talks about dietary advice that women should be being given alongside iron supplementation. Understanding that iron from meat, fish and poultry is useful, but concluding that actually 95% of dietary iron intake is from non-heme iron sources. So thinking about cereals, legumes and vitamin C in the diet. Interestingly, it also mentions that tannins in tea and coffee inhibit iron absorption when consumed with a meal or shortly after. That certainly isn't information I've ever given a woman. Right, we've talked about what to eat. I've focused mainly on vitamins and minerals, but in the RCOG patient information leaflet, there's some nice advice about healthy, balanced diet, fresh fruit and vegetables, 5 a day, relatively low-fat diet, fibre-rich foods, protein. And it also talks about portion size and not putting on excessive weight or feeling the need to eat for 2. So let's turn to my second question. What not to eat? What do we tell people to exclude? So there's a whole section in the RCOG information leaflet about what not to eat, trying to prevent infections such as listeria, salmonella or toxoplasmosis. Let's remember all these are very rare. So with listeria we have avoid eating soft cheese, pate, undercooked food. For salmonella, we've got avoid eating raw or partially cooked eggs or food that might contain them such as mayonnaises or mousses, and avoid eating raw or partially cooked meat, poultry and shellfish. Toxoplasmosis, there's the obvious link with cat faeces, but we've got essentially washing your hands before and after handling food, washing all fruit and vegetable, cooking raw meat and ready prepared chilled meats thoroughly. Seems fair enough. Or is it? Having listened to Lily Nichols on the Midwife's Cauldron podcast, the thing that stuck in my mind from that episode was that actually, in restricting women and telling them not to eat something, we're potentially having a negative impact on their nutritional state. The example she gave was eggs. Actually, eggs are an important source of nutrition. If we tell a woman to not eat raw or partially cooked egg, rather than switch how she eats her eggs, she may cut eggs out of her diet entirely. I found this a very interesting idea. She referred to some evidence that demonstrated that women that stick to the dietary rules we give them have been shown to have a less diverse and full nutritional complete diet than women that break the rules, i.e. don't follow the guidance. This was the first time I'd ever thought about the fact that some of the food restrictions we place on women or recommend or suggest to women might actually be detrimental to the well-being of them and their baby. This had simply never occurred to me before. Why is it important? The example Lily Nichols gave was of choline, the importance of choline, and the fact that choline is almost entirely found in egg. Egg is the main source of choline in our diet. This is where I felt ignorant. I had absolutely no idea what she was talking about. What was choline? Why have I not heard of choline? What was the point of choline? So I delved a little bit deeper. Was this choline thing just a American wacky specialist nutrition thing that I'd never heard of it? But it didn't take long for me to stumble across an article in the BMJ Nutrition, Prevention and Health from 2019. Could we be overlooking a potential choline crisis in the United Kingdom? This is a very interesting article. Choline, it says, can be likened to omega-3 fatty acids in that it is an essential nutrient that cannot be produced by the body in the amounts needed for human requirements. In the US and Europe, the European Food Safety Authority recognised choline plays an important role in the human body and have established dietary reference values. Physiologically, choline is critical for a number of functions across the life cycle, a wide range of roles in human metabolism, from neurotransmitter synthesis, that's message transmitter chemicals in the brain, to cell structure. Choline deficiency is linked to liver disease, offspring cognitive function, and potential neurological disorders. Wow. I mean, really? This sounds kind of pretty important to me. Why aren't we talking about it? Why don't we know anything about it? So I looked down the article a bit further. Okay, that's choline. Let's think about choline in pregnancy. The article goes on to mention that in pregnancy, choline supplementation at about twice the recommended amount improves infant information processing speed. It has been suggested additional choline could improve affective, cognitive and neural functioning when taken by mothers carrying a baby with Down syndrome. Among lactating mothers, intake of choline influenced choline concentrations in human breast milk, impacting on levels transferred to the infant. Human neonates, that's newborn babies, are born with choline blood levels around 3 times higher than maternal levels, indicating high demands during this life stage. Well, I, for one, was completely shocked. So inadvertently, A, I don't know about this very important nutritional element, and B, me telling people not to eat raw or lightly cooked egg may be having a detrimental impact so that they're cutting choline out of their diet. When you come back to the idea of a doctor, first do no harm, that doesn't seem like doing no harm. I may be doing inadvertent harm. Okay, I agree. This is controversial. This has not yet been introduced into the UK. But the evidence that the US and Europe have looked at, the requirements of pregnant women in those countries surely will be similar to the requirements of pregnant women in the UK. we're not a different species. We're the same. So now it does matter that the RCOG information is out of date because it's suggesting people should be cutting out raw or lightly cooked eggs. This was disappointing. But then I remembered there's some leaflets that the midwives give out at work. I vaguely remembered the logo. So I thought I'll look that up and found it fairly rapidly on the internet. Start for Life. There isn't a date on Start for Life, so it's difficult to know when it was last updated. But Start for Life clearly says that actually, these days, the risk of salmonella from eggs is very low, and it gives advice on how to safely eat eggs during pregnancy, and that eggs have the British Lion stamp on them, showing that they're of suitable quality. Disappointingly, there's still absolutely zero mention of choline, but it does at least tell you that you don't need to cut out eggs. One of the things I've always found really difficult about diet in pregnancy is the can't do this, can do that kind of rules approach. And it's difficult for a woman to navigate it. One of the clear pieces of information on the Start for Life NHS website was about fish. Eating fish. Yep, we all think that's good in pregnancy. We all vaguely remember those things. Omega-3 fatty acids, they're good, important for brain development, aren't they? So, yeah, let's eat some fish. But if you go down to foods to avoid in pregnancy, one of the subheadings is fish. So, yes, you should eat fish, but you should eat no more than 2 portions of oily fish. And you should avoid some other fishes. Why is that? Well, sad thing to say is, if you read it, it says you should limit tuna because it has more mercury in it than other fish. You should limit oily fish because they can have pollutants such as dioxins and polychlorinated biphenyls in them. If you eat too much of these, they can be harmful to your unborn baby. Okay, so fish, good, need to eat fish for omega-3, but not too much fish, not the wrong fish, and not fish because we've messed up the fish with pollution. So with everything in pregnancy, it's do eat this, don't eat that. Do eat this, but don't eat too much of it. And what about caffeine? When I was pregnant, having my babies 20 years odd ago, there wasn't any concern about caffeine. I drank tea, I drank coffee. Now, there's a suggestion you can have caffeine, but no more than 200 milligrams per day. And then there's a very clear breakdown of how much caffeine is in a mug of coffee, how much caffeine's in a mug of tea, how much is in cola, how much is in chocolate. It's enough to drive you completely mental, having to work out all these little things of what you can and can't do. And if you're a very laid-back person, this might be relatively okay to navigate. But what if actually you're quite stressed and anxious in any case? I don't see how you would sit down to a meal and keep calm and not start worrying. One of the most telling things about diet is the way it signals to other people we're pregnant. Whether that's not drinking alcohol or switching to decaffeinated coffee or hot chocolate. When we do the coffee run at work, you can immediately tell if a midwife or doctor is pregnant when their routine order switches. In my family, we're Jewish, so the earliest indication at a family event that someone was pregnant was suddenly they wouldn't have the chopped liver starter or the chocolate mousse at the end of the meal. Liver and raw eggs being a no. Immediately, everyone would know you're pregnant. Liver's a funny one. Back to what I said at the beginning, it's one of those ones that's changed over time. It used to be that we would recommend liver, an excellent source of iron after all. But now we know it has high levels of vitamin A, which can be harmful. One of my fond recollections of my grandma when I started going into obstetrics was her telling me about how when she was unwell after one of her births, I'm assuming she'd lost a lot of blood, she said they simply took a crate of stout and put it under her bed, and she wasn't allowed home until she had drank her way 1 or 2 bottles a day through the crate. I don't know why, I love that idea. So to finish, I thought I'd look back at my Glasgow Manual of Obstetrics from 1923 that I've referred to in previous episodes and see what do they say about diet. There's a teeny tiny paragraph. It says light meals taken frequently are usually best, but often pregnant women partake of huge meals throughout the course of pregnancy without any ill effect. They should only eat butcher's meat once a day. They need a sufficiency of vitamins. This is advantageous. And then it quotes one particular hospital where patients are given halibut oil in combination with calcium sulfide, the idea being that the oil supplies vitamin A and D. Well, that's interesting because we know vitamin D is important and likely to be deficient, but vitamin A can be harmful. Fresh fruit and vegetables should be recommended because they contain vitamin B and C. And that's pretty much all it says. So, in a quite fitting way, in an episode on diet, now we get to the zesty bit. Not forgetting that that lemon contains that vitamin C that's going to help us absorb that iron. So what is my zesty bit? I think if you're working in maternity care, my zesty bit is go and review the guidance. Make sure you are up to date. Go and explore Lily Nichols' website. Explore the Start for Life. And don't overprescribe iron. Give the right advice to make sure it's absorbed. Make sure those women that need vitamin D, supplementation or folic acid in a higher dose are receiving it. And don't give misplaced advice, which may lead a woman to exclude certain foods to the detriment of her diet. If you're a pregnant woman listening to this, then you can go and explore some of the same resources. Don't get too stressed about what you should and shouldn't be eating. It's a minefield. You can only do your best and try and make sure that you're having a healthy, balanced diet with a decent variety of foods. Thinking about your diet will help not only your baby, but you to keep healthy during this pregnancy journey, through your birth and into those early weeks and months of motherhood. I do hope you've enjoyed listening to this episode of the obstetricians. Feel free to contact me on Twitter at FW Maternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the obstetricians to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.